All right. This is a patient I saw actually just, yeah, as of yesterday, but saw him this week. I'm on medicine wards. And for the first aliquot, I'll share that this is a 40-year-old male. He has a chronic indwelling Foley catheter, and he presented to the emergency department because of 1 day of lower pelvic pain and a concern that the quantity and the color of the Foley output had changed. So I'll give you more information a little bit later, but I'll pause here for the first aliquot.
Yeah, Maddie, I think this is not an uncommon place where somebody who has an indwelling Foley catheter has discomfort that's potentially related to it. And I think you both have to be anchored in base rate, but also be a little bit cautious because the base rate would be that if somebody has any pelvic discomfort with a Foley catheter, it's easy to implicate the Foley catheter. But I think you have to be careful and try to make sure that that there isn't something parallel going on. And I think that the ways that the Foley catheter would be implicated are two ways. The first is it's causing a mechanical obstruction, in which case you would try to flush the Foley catheter and you would not be able to get any return. And or you would do a bladder ultrasound and see that the bladder is full despite a catheter being in it, and that would implicate the Foley itself. The other common way that Foleys can cause pelvic discomfort without any mechanical obstruction is they serve as a nidus for bladder spasms. And so some patients, unfortunately, really don't like the Foley and their bladder contracts on the Foley catheter. And those patients are very difficult to confidently diagnose, except making sure there's nothing else going on. And they often have a response to an antispasmodic like oxybutynin, which is an anticholinergic medication used for neurogenic bladder. So how could the Foley be implicated here through a mechanical obstruction, which is teased out by trying to see if you can flush it and or looking at an ultrasound to see if it's in the bladder, with further support being gained by the fact that the patient's making less and less urine. But bladder spasms are real. They're hard to definitively diagnose unless you've ruled everything else out. And of course, study the character of the pain. I think an important question to ask in parallel is why does a 40-year-old man have a chronic indwelling Foley? Um, the most common indication for chronic indwelling Foley has to do with the bladder system not working, often as a result of outflow tract obstruction, usually from benign prostatic hyperplasia, though sometimes it can be from the bladder muscle itself not being happy. And so I would surmise that based on his age, that the BPH is less likely, and that he might have uh, a chronic neurological condition affecting his bladder muscle tone. And if that's the case, and he has spinal cord disease or advanced peripheral neuropathy, you have to be very careful. And the reason I say that is his ability to communicate pain and feel pain is very different than others, and what might be a mild presentation of more spasms or pain in his pelvis may indicate a really, really serious underlying condition. I, I remember a very, very tragic case in residency where a patient with multiple sclerosis came in and said that she was having more discomfort in her pelvis. It seemed very benign history, only for her white count of 30 to tell us that she actually had peritonitis. So a lot of things to tease out here. I think the open questions are, why is this 40-year-old person having this vulnerability of this Foley? And then in parallel, is this acute issue related to the Foley mechanically or spasmodically? And is it not? So I'd be trying to answer those questions initially.
All
Back to
right,
you.
great. So we'll give you a little bit more information. This 40-year-old, he has a history of spina bifida and paraplegia. And so he lives full time with his sister, who's basically his full-time caretaker. And 2 days before coming to the emergency department, the sister noticed this black residue in the Foley. And then 1 day before he presented to the emergency department, the patient noticed this intermittent suprapubic pain. And so the patient told his sister about that, and the sister was like, "Okay, well, tell me if the suprapubic pain comes back, because if it comes back, maybe we need to go to the emergency department to see if you have an infection." So the pain did come back, the suprapubic pain, and so they called the ambulance and then went to the emergency department. So in addition to the suprapubic pain and then this kind of black residue in the Foley, The patient also reported that he felt like there was decreased urine output in the Foley. So he says usually he notices that the bag has like 500 cc's, and he had only noticed there being 200 cc's. And the daughter had also reported that there was some leaking of urine around the Foley. Review of systems is overall negative. So pertinently, no fevers, no chills, no back pain, no dysuria, no confusion. And that's really all the information from the HPI. So for this past medical history, I mentioned spina bifida and paraplegia, and he has these chronic sacral wounds from immobility. And he previously had been on doxycycline and ciprofloxacin as basically like suppressive antibiotics to prevent osteomyelitis, but he is not currently taking those. He hasn't taken them in many months. And then in terms of this Foley history, so the reason for his Foley was for the Foley placement. The Foley was actually placed like a year and a half ago. And the reason for the Foley placement was to avoid contamination of these sacral wounds. And what's great is he actually has a lot of support at home. So he has these home health nurses that come every 2.5 weeks and replace the Foley. And so the last time this Foley was placed was 2.5 weeks ago. That's the last time the Foley was exchanged. Besides that, he has well-controlled type 2 diabetes on metformin. His last A1C in the chart was 5.7. He has a history of a venous thromboembolus. He's on Eliquis for that. He has hypertension. He's on metoprolol losartan for that. And those are all of his medications. I mentioned the social history, lives with his daughter full-time and has a lot of support at home. No other pertinent social history, no relevant health-related behaviors, no relevant family history. And then I will give you the vitals and physical exam from when he came into the ED. So vitals wise, he was afebrile and the rest of his vitals were totally normal. Physical exam, so, I saw him kind of after he was admitted, but he was sitting in bed in no acute distress. He, I'll kind of focus on what was documented in the ED. So in the ED, it was documented that there was kind of urine leaking from the urethral meatus. There was no discharge, there was no bleeding. And the urine in kind of the Foley bag that he presented with had significant sediment. By the time I saw the patient, the Foley bag had been exchanged and there was a normal color. And I didn't mention this in the medical history, but he actually also has an ostomy in place in the left side of the abdomen. And he reports that he has an ostomy also to aid in like the healing of these sacral wounds. No other pertinent findings on physical exam. And I'll pause there.
Prof Rez in the house. What you eating?
I went from a breakfast sandwich to a hash brown, just 2 of them, to the mini donuts that you would love. Well, Maddie, very nice to see you.
Good to see you. I don't know where you jumped in, but I'm happy to summarize any part of it in case you didn't catch it.
I heard all of Rabih's poetry and I heard your presentation. And I'll just share my reflexive thoughts, but really we'll want Rabih to layer upon those. I think a case like this can feel intimidating because of the past medical history. For example, like I myself am not that confident or have like a robust illness script for spina bifida, and knowing the complications that might occur over time because of that disorder. But what I do know is that it's a neural tube defect. It leads to an opening in the spinal cord, and the severity of that can vary greatly from individual to individual. So we're worried about vulnerability to the spinal cord, both mass effect and infection, or infection leading to mass effect. And I think here, just to make it very clear for the audience, when someone has all these sacral wounds, which I imagine is related in part due to the spina bifida and his paraplegia that I'm seeing here, you really want to avoid contaminating that area. And one way is through a Foley. And if you know it's going to be a long-term solution to divert the urine, you might actually err on the side of doing a suprapubic catheter, because that has actually a less risk of infection than a Foley catheter. And the easy way to remember that is suprapubic catheter is so small, while the Foley catheter is so long, and the longer the catheter, the more at risk you are of potentially acquiring an infection from the environment. And then the ostomy, again, it's doing the same thing. You want to take away those gram-negative organisms and anaerobes from potentially contaminating the impeached skin on his lower back. But Rabih, like for me, I just like really simplify this exercise. One, no dysuria is not that helpful when someone has a chronic indwelling Foley, like they can't feel dysuria or urinary frequency. Really what you look for urinary tract infections in those with Foley catheters is suprapubic pain, is decreased urine output, is signs of systemic inflammation. So the problem we're solving here is suprapubic pain and decreased urine output. And like what my mind does for decreased urine output is convert that into, AKI. And then the AKI, you just go pre-renal, intrarenal, post-renal. You most certainly would want to do a bladder scan. You may even want to do a renal ultrasound to see if there's any evidence of hydronephrosis. You're going to want to review the medication list very, very closely because that can be a cause of pre-renal and intrarenal. You're going to get fluid to see if this patient responds to that. But AKI wouldn't explain the actual pain the patient's suffering unless it's like an obstructive process. But Maddie told us the Foley was exchanged and urine came out. For the pain, you have to think about UTI. And interpreting urine cultures can be difficult. But if someone has suprapubic pain, decreased urine output, no alternative anatomic etiology for it, I'm fine calling it a catheter-associated UTI and treating it as such. So for me, Rabih, I think it's like anatomically, I'm trying to understand what's causing this pain. Is it just a UTI and something that's not like robustly image positive? Or are we going to get a CT scan and there's going to be something more prominent? But I don't even think I would yet necessarily get a CT scan if it's just suprapubic pain. I also noted that dark sediment, Rabih, in the urine, like that made me think, could there be a fistula of some sort? He's had all this altered anatomy internally. And is that actually fecalith material that then predisposes to infection and catheter obstruction from said infection? Anyways, I don't really know what I'm doing right now, but what I do know is I'm going to pass the mic to Rabih. That I know for sure.
Well, Prof. Rez, that was incredible. I have absolutely nothing to add to what you're thinking. And I love these opportunities to talk about common things that affect people. And I'll just take an opportunity to talk about something completely separate, which is the leaking of the urine, which is maybe not a conversation to focus on now because it's resolved and the patient has the catheter exchange and everything is good. But you might be in the situation as an intern or a medical student when you're trying to wonder, hey, like my patient's, how is it possible that my patient's urine is leaking when they have a catheter in place? So let's just take a minute to understand that because I have nothing to add to Prof. Rez's thinking about the medical case. So I think to understand the space, you just have to remember one simple fact, that urine is going to follow the path of least resistance. And if there is a typically functioning Foley catheter with a balloon inflated in the bladder, the Foley catheter opening is way, way wider than the tiny spaces between the bladder opening and the Foley catheter. So if you imagine that the Foley catheter is entering into the bladder, there's maybe 2 or 3 millimeters on each side of the bladder opening where the urine can come through. But why would the urine choose to go squeeze through those tiny holes when it has a wide open Foley catheter hole to go through? And so that's why, even though there is space between the catheter and the bladder outlet, it chooses not to go there because it's a space that it has to push through. It goes right through the Foley. And so whenever somebody is leaking, you just have to visualize that the urine is choosing to go the hard way. And the reason it's choosing to go the hard way is either there is an obstruction in the catheter and the wide open hole of the Foley catheter is not available to it because there is something wrong with the catheter. Either it's occluded from the inside by thick material, or there's something blocking the entrance of the actual hole, like a large bladder stone or a large clot on the clot. So the path through the Foley is not an option because of an obstruction of the catheter in some way, shape, or form. The other possibility is the path that the Foley catheter is not available. And the reason for that is now the balloon is deflated and the Foley catheter is in the urethra itself. So why would urine choose to go around? It's either the path through the Foley is blocked or it's no longer available and the Foley catheter is now dislodged all the way down. And so the reason you have to think about that as you move on from this case is the folks in the ER have fixed the urinary leak, right? They've put in another catheter. But what did they fix? Was this patient obstructed before and now you've relieved their obstruction? Or did this patient have a Foley catheter lying in his urethra for a while? And did he suffer some consequences of that irritation of his urethra? And the latter hypothesis would leave the patient with residual pain and discomfort, and even more pain and discomfort upon reinsertion of the Foley. But as Prof. Rez said, there's a possibility that he was obstructed for quite some time, and the folks in the ER just quickly fixed that. And sure, he may be getting better, but while he was obstructed, did he suffer some consequences? Did he suffer acute kidney injury as a result of that obstruction? Did he suffer stasis and a superimposed infection as a result of that obstruction? So those are things that Prof. Rez brought up, and I think you still have to think about them, even though the issue has been apparently addressed. All right, Maddie, mic to you.
All right. Love this discussion. All right, so for some initial labs that were done in the ED, so his CBC was totally normal, pertinently no leukocytosis. His BMP was also totally normal. His creatinine was normal and was at his baseline. They got a UA that was cloudy, moderate blood, large leukesterase. There was greater than 75 white blood cells, negative nitrite, and moderate bacteria. And those are really the pertinent findings on the UA. So be curious at this point to kind of ask you both, Rabih and Reza, what if you would give this patient antibiotics? And to help with that decision, I imagine if you were making that decision, you would probably look back at previous urine cultures. And so he had a urine culture from 3 months prior that I can show you just to inform your decision of like, if you would give this person antibiotics and if you would, what you would give them. So maybe I can just share the screen of like what the previous urine, or I can just tell you. Let me just share this. So this, am I sharing my whole screen? No, it's just the photo, right? Okay, so this is not from the current admission. This is from like 3 months ago. You just look back in this chart, and 3 months ago, he had a urine culture with these results. So yeah, curious what your thoughts are on the UA. Would you give this person antibiotics? And if so, what would you give them?
Can I be honest? I'd love to hear how Prof. Rez approaches this. I feel like we got to learn from the master.
Can we go back to the other screen, Maddie?
Yeah.
We all noted that was Pseudomonas at 1 to 10,000 colony forming units. I think so whenever you have a UA, you're looking at a few specific components. One, you're seeing, are there white cells or not? And the correlate of white cells in the urine is leukocyte esterase. Like that's an enzyme in white cells. So whenever you see white cells, you should see leukocyte esterase. Now, something that's more specific than white cells or leukocyte esterase that further support, the notion of a possible UTI, because Rabih has a song. What's your poem, Rabih? Can you just share the poem real quick? And then
you also have to sing it.
Go for it.
Wait, I think Maddie knows it.
No, I was saying it's the song. You have to sing it, Rabih.
I can't sing it. No, I'm not going to sing it. I only sing it for people in the academy. You have to earn the song. But I'll say it. No symptoms, no UTI. No pyuria, no UTI. No bacteria, no UTI. It's much better as a song, but hey, you got to work for it.
And that's actually such a perfect song because it allows us to talk about the nuances of when someone actually has a catheter. And then it also highlights that Rabih didn't say no nitrite, no UTI. He didn't say that. That's not part of the song. So the nitrite, if it were positive, it would just prioritize. And Enterobacteriaceae species like E. coli, Proteus mirabilis, etc., that can convert nitrate to nitrite. But you can still, for example, be infected by such an organism, but just not capture the nitrate. So it's like one of those studies, if positive, pushes you towards what the organism might be only if the patient has a compatible syndrome. So I think before we even look at this urine, we have to ask, is there a compatible syndrome for catheter-associated UTI? This is different than a UTI. It's really important for you guys to understand this, because with the catheter in place, those urinary symptoms are not there. Dysuria, frequency, they're not there. So you have to rely on obstruction of the catheter because of the inflammation from the organism within the catheter, or suprapubic pain. Those are the local symptoms, or systemic signs of inflammation. And in this case, Maddie, for me at least, I would be like, okay, he was obstructed. And you can't use the color of the urine, the smell of the urine. None of that actually helps in diagnosing a catheter-associated UTI. He was obstructed. He has suprapubic pain. I don't have an alternative etiology. My operating hypothesis is catheter-associated UTI, and he has risk for it. He has a chronic indwelling Foley. And so then the question is, what organisms would I cover, or how aggressive would I be? The fact that the organisms that people are at risk of are all the common organisms, your gram-negative organisms that we mentioned, but they're also at risk of other organisms like Staph aureus, Pseudomonas, fungal organisms, all of the, and when you say nitrite negative UTI, it does bring to mind like Enterococcus, it brings to mind Staph, it brings to mind Pseudomonas, it brings to mind fungal. I wouldn't be giving this guy empiric antifungals for sure. I would wait for the urine culture results. But would I treat him with empiric antibiotics, and what antibiotics would those be? I would treat him for a catheter-associated UTI because that's my operating hypothesis as urine cultures are pending. And assuming those were obtained before antibiotics, they're the definitive test. They're the definitive test, and everything else is compatible. Again, I don't have an alternative explanation for the suprapubic pain. I have a catheter that's obstructed with no explanation. I have a patient that's vulnerable with type 2 diabetes and a chronic indwelling Foley to arrive at this working. And yes, he's not septic, so I don't think you have to be too aggressive. But I would probably treat him for your run-of-the-mill catheter study. I would cover Pseudomonas. That's the one I would cover. The nitrite's negative. I know he's not very sick, but I would empirically cover it without a question asked. And then I would just wait for the culture data. I wouldn't start vancomycin yet. Like, if this guy was sick, I would also do vanc, because Staph aureus could be a contender. And you might even consider ampicillin if they were really sick for Enterococcus coverage. But Rabih, I think this is such a great area. Like, I would really like your honest, earnest feedback. For me, I'm calling it a catheter-associated UTI. The prior culture Pseudomonas, this is nitrite negative. I might give something like Zosin and cover both the common organisms and cover the Pseudomonas.
Yeah, Prof. Reza, I agree with you. I think there's so many people who do different things. And I think if I were to zoom in on your teaching, there's really objective, concrete things that you can learn about how to properly interpret a UA, which you just told us, and how to properly rely on urine cultures, which you just told us. And I think the ambiguity in the decision-making for people isn't how to interpret a UA or how to interpret a urine culture once they're residents or attendings and have had that introduction to those tests. It's all about, as you said, do they have a compatible clinical syndrome? Right. And if somebody came in and they told you they have knee pain and somebody gave you a UA, you wouldn't use that UA at all. And so I think that the dilemma here is, what is the DDX of what is causing his symptom complex? And for me, this is why it's so important to be very, very precise in two things. What is the concern that he came in with, and what are the possibilities? And then two, what are we really trying to accomplish for him? And so the question lingering in my mind is, why was his urine leaking? Because the urine leaking relates to his pain. And so if his urine was leaking because he has a urethral Foley catheter that slipped into his urethra, and that's why he's in pain, then I think the only return on investment I'm going to get by giving him antibiotics is possibly treating an active urinary tract infection. But realistically speaking, given his life trajectory, increase the chances that he has a resistant organism a few years from now? Because this is going to be somebody who is at risk of getting hundreds of urinary tract infections over his hopefully normal 40, 45 years left of his average lifespan, right? And so that's why I think it's so important, which is often not done in busy emergency rooms, to be precise. And by the time that Prof. Rez is being called to admit a patient like this, you often don't know what caused the urinary leak and what caused the pain. So if I were in the position that you're in, Prof. Rez, quite often, I don't think you can take a risk. This person grew serious organisms in his urine. You don't know if it's a mechanical issue or an infection issue. Why would you take a gamble, especially if the ER is calling you to admit somebody? I mean, geez, they're sick enough to be admitted. How could you not give them antibiotics? But I think if you're the frontline provider seeing this patient, you have an opportunity to balance the risk of a current infection with the risk of antibiosing a person to increase the risk of C. diff. And then when you think about the fact that he is going to get hundreds of antibiotics over the course of his life, think about the 80-year-old version of this vulnerable person rather than the 40-year-old version. So I think you're stuck probably, unless you were lucky enough that somebody was thoughtful about engaging in a DDX before removing the catheter. Once the catheter is gone, it becomes tricky, although you might now ask the patient before you do anything, hey, how are you feeling? And if he tells you, I feel great, I'm ready to go home, then you're not accomplishing anything with antibiotics. But if he's telling you, yeah, I still feel uncomfortable, you'll never know if he has a urethral trauma that's causing him discomfort or he has a UTI. So that's my take. I'm curious what you think about that, Prof. Rez, and how that lands with you before we hear from Maddie.
Oh man, I think that's such a great balanced approach of like thinking about future risks, etc. And you're absolutely right that like most often a patient like this, by the time I see them, would have already been initiated on antibiotics, most likely. And I find it a bit difficult to know that like, because he's having just local symptoms, if I place in a new catheter and I took away the obstruction caused by inflammation from the underlying UTI, does it really mean that I've treated said UTI, or does it take time for that sediment to form? And I'm just theorizing now. But yeah, I don't think you'd be fault either way. For me, this is much different than someone who's like older and has like a positive urine study and is altered. That's like clear for me. This is a little more difficult because, like you said, I don't know what's causing this obstruction, and it's something within that Foley catheter. And the most likely and easily explanation for me, at least, would be a UTI and inflammation.
Makes sense.
We shall see.
Yeah, such a good discussion. I love kind of the different perspectives of like, when this person is just, you're receiving a call from the emergency department versus the perspective of someone just seeing them. I think we'll kind of get to that at the end. But I'll move on. So in the ED, as I mentioned, the Foley was removed and replaced, and the urine cultures were sent from the urine from the new Foley. And so what the ED decided to do was that, given the UA findings, the report of this discomfort, urethral irritation, and the previous urine culture data, the ED had decided to start this patient on Zosyn. And so he was admitted to the team I was on in the morning. It was like an overnight admit as a catheter-associated urinary tract infection, and admitted to basically await urine culture results and susceptibilities to make sure he gets on the right type of antibiotic. By the time I saw the patient in the morning, he was feeling completely well. He had no suprapubic pain, no discomfort, was feeling very well. And kind of a day later, the new urine culture grew greater than 100,000 Pseudomonas and greater than 100,000 E. fecalis. And I will pause there. That's kind of all the data we have before I share kind of what happened in this case and what we were thinking.
Guess what? I got to return the favor. I'm really curious, Prof. Rabih. What would you be thinking about after structure?
Oh my God, Prof. Rez. Oh, one. For all of you, Maddie is going on a cruise paid by CP Solvers because we finally, Prof. Rez, I keep telling folks that someday when somebody presents a UTI on VMR, I'm going to pay for their cruise, like a whole shebang. So Maddie, congratulations.
Where am I going? What type of cruise?
You get to decide wherever you want. By the way, you don't know if this is a scam text or not. I'll acknowledge.
I know. I feel like I've gotten those scam texts. Like, you won the lottery and you get to go on a cruise.
Yesterday, I got a text from the DMV that I had an unpaid ticket, which of course is not true because I'm so paranoid about that stuff. But it was so cool. It was like my DMV, and then it had a Z at the end .ca.gov. And I was like, ooh, you almost got me there.
I've also gotten so many text messages of like, you have an unpaid ticket, and it freaks me out.
Yeah. Well, now
And
you have a pending cruise with a Z, maybe. We'll see. So what do I do here? Prof Res, to me, this is a personal philosophy. It's not a written in evidence. If the patient is happy, so am I. And so if he's happy, so am I. And the question is he happy because there was nothing wrong with him and he had a mechanical issue? Or is he happy because of the Zosin? And I think that is an impossible question to answer. The improvement of him with either time or Zosin reduces the ability to implicate the Enterococcus faecalis unless it is beta lactam sensitive. So for me, either the Pseudomonas the E. faecalis is probably reduced in its significance if it's vancomycin, if it's a beta lactam resistant. So that'll be interesting to tell. So either the Zosin made him happy or he was always happy. He just had a mechanical issue. And I think if I were to be able to really tell you a confident answer, I had to have been there at the bedside to see how quickly he got better with relief of the obstruction. So what do I do in real life? I actually tell people the dilemma that we're in and to see if the patient has a strong opinion. And sometimes patients are like, Doc, I've taken so many antibiotics. I'm feeling great. I'm just gonna not take it. And if I get sick, I'll come back. And I've had others say, Doc, it's a 5-hour drive from Eureka to get here. Just give me the antibiotics. I don't want to risk it. So I don't think this is my decision to make now. I think the accurate reasoning here would be to say that the inability to distinguish between symptoms from a mechanical issue versus a UTI, leave it totally up to the interpreter. And so if the patient has a strong opinion, I would not counteract their opinion. If they didn't have a strong opinion, as is often true at the VA, and say, what would you do, doc? If I were him and he were a family member of mine, I would prescribe him antibiotics, but tell him not to take them at all unless he starts to get worse. So if I were the decision maker here, as suggested by the patient, I would prescribe him appropriate antibiotics, keep them in his bag, and only use them if he were to develop more problems. That's probably how I would settle it out. What about you, Prof?
Can I just share my screen real quick? I just want to show you guys, like, this came from one of our RLR episodes. And I just want to take you on this beautiful journey that, like, the catheter-associated UTI went to suspect, just breaking it down to urinary specific. Let's ignore this stuff because we know this isn't at play right here, the extra-urinary. But what you can see, it's obstruction and retention, it's suprapubic pain and tenderness. And then if it involves the kidney, flank pain and tenderness. And the risk factors are here. Duration of Foley, right? And diabetes. Like literally, we're almost putting this guy's on our illness script. And the DDX, whatever I have here, but here are the organisms: Pseudomonas, Enterococcus. And then finally, I think it's very important to mention that if it's like recurrent infections and someone with chronic, you really have to refer to urology for suprapubic catheter. This can be a little bit of a game changer. I've done it before. But dysuria, frequency, urgency not present until catheter removed. And he didn't have any once the catheter was removed, it seems like. And the urine smell and appearance is not helpful. This is a very good illness script, by the way, if I may say, in a very biased fashion. A lot of thoughts what to put into it. As far as what I would do, I would follow Rabih. Honestly, I think it's a very sound approach. I think that it takes a lot of confidence to be like, let's say this, if this were a pneumonia and the next day the patient got better, we would be like, this is not a pneumonia. It was an aspiration event. So the only challenge I have, Robbie, here is whether that obstruction, right, is due to the inflammation, and that takes time to develop. You see what I'm saying? Rather than it just being the catheter was moved down into the urethra. So I can imagine a universe in which there truly was infection and truly the main reason for symptoms was a mechanical obstruction, and reversing it with the Foley could treat that, and it takes time for that obstruction to occur. That's all I have to add. I really don't have a strong, I think it's tough and it's nuanced.
I just wanted to jump in and say I love the analogy with aspiration. I think that's such a cool one, Prof. Rez. And it triggered a thought with me about when we give antibiotics and what your illness script did about exchanging the Foley. It just reminded me of abscesses and when we drain abscesses. I feel like we're in a situation here with the Foley, no different than what your illness script said about the role of exchanging the catheter with eliminating the source. So the value of antibiotics for a skin and soft tissue abscess is so low that our practice pattern is you just drain the abscess and discharge the patient. Antibiotics add very, very little. And there's a really nice NAJM that proved that. I think this is essentially what we're getting at here, Prof. Rez, is you can debate the additional role of antibiotics. What's really important in this person is to address the Foley. And I think I love that the script emphasized that. I think that's key. None of us have debated whether the Foley should be exchanged or not. That's 100%, I think, the standard of care and really, really important.
Dude, that's so wise, man. And I'm there calling this I personally am calling this a Cowdy. And now the question is it Pseudomonas or I don't know if there's going to be time, Robbie, but I would love to hear. Well, yeah, I'm calling this a Cowdy. So I guess like technically I would treat for 7 days because I'm calling it a Cowdy, but that would be my recommendation to the patient. What I would treat with is a little more difficult. Like I would have to talk either to ID or look at some, so like what can cover both, or do I have to use 2 antibiotics, whatever. I'd GPT that. Or am I putting a PICC line in? I'm not putting a PICC line in, guys.
All right. Yeah. So this is a really great discussion. So basically, kind of what happened in this case is that based off of the resistance on susceptibilities from the previous urine cultures, there was concern that the patient might, I don't know if OPAD is a word used, and like, is that a universal word or is that specifically just in Colorado? But there was concern that we need to bring ID on board to figure out, does this person need OPAD, like IV antibiotic therapy based off of the susceptibility pattern? So we actually initially got ID on board. But as you both said, when we took a more detailed history with this patient, it became clear that his symptoms completely resolved after the catheter was exchanged in the emergency department. And so based off of the fact that the symptoms resolved immediately, the fact that he didn't have any systemic signs of infection, as you all pointed out, no leukocytosis, no fever, actually the way initially, he was admitted as like a catheter-associated urinary tract infection. He was treated as so. And initially ID was on board to like, do we need to get him IV antibiotic therapy based on the resistance patterns? But with this additional history that the symptoms resolved immediately after Foley change and the lack of systemic symptoms, our thinking at the end was actually that these represent colonization and not an active infection, and that the cause of the symptoms was basically Foley malfunction or like an obstruction, as you all talked about, that was causing the urine to leak. So we kind of had this discussion with the patient, went through our thinking, and he actually wanted to go home. And so we discharged him yesterday. And he has follow-up. So yeah, basically initially admission for a suspected CAUTI, but we think that this was likely a Foley malfunction and that the urine cultures were colonization. So we discharged him without antibiotics.
I love that. Like getting another subspecialty service involved can be very helpful. But then, Maddie, what was causing the Foley obstruction?
So I think that's hard to know. And I think what's tricky is that in my position, I kind of wish I was in the emergency department and saw what the Foley looked like, but I wasn't. Like I got kind of the sign out afterwards. And so I don't I don't entirely know what was causing the obstruction. The patient had said like he had a picture, the sister had a picture on their phone of like what the black sediment was. And I was like, oh, can you like show me the photo? But the sister wasn't there. So I never got to see an actual photo of what it looked like. So I don't have a clear answer of what exactly was blocking it. Was it a stone? Was it kinked? Did it kind of like, I think as Rabih said, did the balloon, did it just kind of move distally and it was in the urethra? So I'm not sure which one of those, but we think it was some type of just Foley malfunction rather than a CAUTI. But I guess that kind of it will be like the test of time to see how he does without these antibiotics.
Honestly, because every infection has to start somewhere. Like there's a spectrum. It's not that people present with rip-roaring sepsis. Like, and we know this in reality. Like if you think about people who have pancreatic masses, if it's on the head, we get an early clue with jaundice. If it's on the tail, we don't. So I can easily fathom a scenario where you have early signs, like early signs of catheter-associated UTI with the obstruction, with the organism, and said symptoms. And the patient comes to attention early, and the Foley catheter is removed, that obstruction is alleviated, and they feel better. So I don't know. I think it would still be very reasonable for someone to give a 7-day course and call this CAUTI. But again, it's a different spectrum, different severity. Another thing I'll say too is like something I need to look up, because if all that obstruction is due to the bacteria causing inflammation, and if you remove said Foley catheter, do all people with CAUTI, if they have only localizing symptoms, not systemic symptoms, right? Because that's in the blood, just localizing, does everyone improve with just the Foley catheter exchange initially? I don't know the answer to that. And that's something I'm going to review, because I think that would be the most, like if I read that, hey, in localized urinary symptoms and CAUTI diagnosis, if you exchange a catheter, they still have suprapubic pain or whatever, then I agree. This can't be CAUTI. But yeah, I guess this just really is a great case because it gets down to the true fundamentals of like, how does these specific urinary symptoms come to existence with a bacterial infection? Is it literally just pus and inflammation, like Rabih said? And therefore, even without antibiotics, you remove it, exchange it, it should get better. And what we're seeing here is that we're just seeing early CAUTI, which we've never thought about, Rabih, versus more severe CAUTI. I would love to hear both of your thoughts on that.
Yeah, Prof. Rez, I think, with you and I working in the place that we work, I think we have some really fun patient interactions where I feel like patients are a little bit more frank. So I'm just imagining a patient who didn't want antibiotics and would say like they would probably ask me like, what are you trying to accomplish here? I feel great. I want to go home. Why do you want to give me antibiotics? And if I think that through, like what are we trying to accomplish by giving a patient who feels great antibiotics? And the things I can come up with are to reduce the chances that they get severe infection and to reduce the chances that their catheter obstructs again. Can you think of anything else? Like would be asked, like if this person is right in front of us now, can you think of anything else that, because I'm doing this in real time.
I love that frame. That's a very powerful frame. Like if like we've already removed all the Foley that was colonized that can further travel upwards and wreak havoc, what else are we? I love that frame.
Yeah, and so I think if you're just take it from that angle, I think you're like, okay, well, what are the chances that antibiotics are going to reduce the chances that this person gets sick? And I don't think that's very difficult to answer. Which is why ultimately this may seem like a unique dilemma, but I don't think it is. This is the exact dilemma that frontline providers put hospitalists in all the time when we give broad spectrum antibiotics to undifferentiated fever without sepsis physiology. And then the admitting team and the hospitalist team are like, do I continue these for 5 days, 7 days? Nothing grew out in the culture. So I think that the only reason we're in this dilemma, I think, is because empiric treatment, Foley exchange, was done without diagnostic clarity. You didn't need to rush and quickly exchange this Foley catheter without being like, why is it not working? Breathe. Is it blocked? Is it misplaced? And you can see the downstream consequences of the lack of diagnostic clarity when that empiric treatment of the Foley exchange was done without knowing why you're doing it. And that happens all the time. And I understand it. Believe me, I do it all the time. But I think this case highlights that we would not be in a dilemma at all if you did an ultrasound and you saw there was actually the bladder was not full and you couldn't see the Foley balloon. And you're like, oh, this is urethral trauma. And you just remove the Foley and you're done. The patient would be discharged. Instead, the poor patient got admitted. Yeah, we think it's such a light thing to be admitted in most people, but like, gosh, if I had to go to the hospital now and be admitted, I'd be frustrated. What about my acai bowl? Oh my gosh, horrible. So I think the general tension here is it's really, really important to ask yourself with any time that you are doing something to the patient, one of two things has to be true. Either it's an emergency and they're too sick for you to be precise, or you should know exactly why you're doing it. Otherwise, it may not be a problem for you, but it might be a problem downstream for the patient and other people thinking.
Dude, that's so clever because, like, let's say we just obtained urine cultures on this person and they had no symptoms. No one would treat.
Yeah.
No one would treat. Zero. So, like, was that a fake out? That's such a so either I think the final diagnosis is that this thing was lower in the urinary tract, or it was early caudy that was just starting to make its fingerprint. And I think regardless of what it is, Maddie still deserves the cruise because I don't think there's a single episode in CP Solver's history where we talk about UTI. Every other word has been there. This is probably one of my favorite cases, honestly. I love it so much.
Yeah, this is a treat. Maddie, I love your reflections, and then we can pass the mic to Zachariah for his teaching.
Yeah, I mean, your discussion was just, both of you it was just so brilliant. And there was just so much gray area in this case, which is why I wanted to present it. I think first, the way I got this case, like sign out in the morning, like admission for a caudy on SOSN. And so I think it's really hard to not anchor on that. And I feel like it would take a lot from the team that I was on to be like, oh no, this is colonization. Let's stop antibiotics. But I think what you all pointed out, the symptoms were, the song that Rabih has, right? Like no symptoms, no UTI. It was really hard to distinguish if the patient had symptoms that were consistent with the urinary tract infection here. And I think there was just so much gray area. And I feel like I have this tendency to like not, be hesitant to, I want to really know, like, does this person actually have symptoms? Does this warrant antibiotic therapy? But it was hard to just kind of stop the momentum that had already been started with the catheter-associated urinary tract infection. As I mentioned, we got to the point of like consulting ID to see if this person needs IV antibiotic therapy. And then it was really the discussion with ID and retaking that history where they're like, the symptoms immediately stopped after they changed the Foley. He has no cytosis, no fever, no kidney injury, nothing. Like, this is maybe colonization. But I think it's really hard to stop momentum, I think, once it's started. And then it was very challenging to clarify if this person had symptoms of a urinary tract infection or not. And so the gray area was challenging to navigate, but I think you guys both highlighted that so well.
And I know we're running short on time. I just wanted to reflect on that, just saying that how much easier would this be if it were a presumed pneumonia and the patient got better the next day, the hypoxia resolved, the white count resolved? We'd say it's aspiration pneumonitis. Or this is presumed cellulitis, and the next day there's no redness. We would say this is venostasis. I think here it's a little more difficult because I think the local symptoms, and I'm going to fact check myself, but you guys do that on GPT. I think the local symptoms are from the inflammation due to the bacteria. And like if you remove that inflammation by literally removing the Foley, you no longer will have those local symptoms. So I think this one's a little more, even more difficult than the other said cases.
I love it. Maddie, do you know what else has a lot of momentum and is really, really hard to slow down?
What?
A cruise ship.
Yeah.
I thought you were going to say Prof. Rez giving antibiotics or steroids.
Mike to you, Zachariah.
All right. Thank you so much for the case, Maddie. Amazing discussion. We started off the case where we presented with pain in a patient with a Foley catheterization, and Rabih then expounded on that it can be because of one of two options. The first is that the patient either has a mechanical obstruction And we can easily confirm that by trying to flush the catheter, and we can confirm that with the ultrasound. And the second is that the patient could have a bladder spasm. And then we reviewed some of the indications for long-term urinary catheterization, and that's mainly in older males with sort of obstructive uropathy, which wasn't the case. In this case, it was because of a neuromuscular or spinal cord problem. Some other indications would be acute urinary retention that's not managed by other means, or in some advanced stages of pressure ulcers. And then also Prof. Rez added later on that in a patient with sacral wounds, suprapubic catheterization might be a better option. Then when it comes to diagnosing a UTI in a patient with an indwelling catheter, they don't present with the typical symptoms of dysuria frequency. Generally, they present with decreased urine output, some local symptoms, which can be suprapubic pain because of the inflammation, or they could present with systemic signs of illness. And then Rabih went through that the point that if a catheter is leaking, you need to think about it carefully, because urine generally follows the path of least resistance. So if it's leaking, then it's possible that is then an obstruction within the catheter. So that could be actually within the tubing of the catheter, or the entrance could be blocked by something, whether it be a stone, clot. In this case, it was likely possibly inflammation or something that blocked the tube, versus migration of the catheter and migration down into the urethra. And then also some nuances about when to consider giving antibiotics with a catheter-associated UTI, COTI. And like Prof. Rez said, if the syndrome fits, so there's local symptoms, and that's most likely suprapubic pain or systemic signs and symptoms. However, one should err on the side of caution when giving, or on the side of caution, and rather give if the patient is systemically unwell. And then what drug to give? The Prof. Rez went through some of the nuances with that. Obviously, cover for Pseudomonas because the patient had a past history, but also it's common in patients with indwelling catheters. And then cover for the usual bugs. Prof. Rez also went through some interpretation of the urine analysis in the context of UTI, and white cells or leukocyte esterase would be indication that there'll be some white cells. If there's no nitrites, doesn't necessarily mean the patient doesn't have a UTI. Nitrites just indicate specific bugs that produce that, E. coli, Proteus, etc. And then Rabih and Reza's song, no symptoms, no UTI, no bacteria, no UTI, no pyuria, no UTI. And then, like we were discussing earlier, when dealing with a COTI, you'd want to consider all the common organisms, but in addition to that, consider staph, Pseudomonas, Enterococcus, and some fungi. And then also, when also giving antibiotics, or we can extend that, as Rabih was saying later on, when we do anything in the ED, we always need to think ahead. Are we doing good for the patient? Are we doing harm for the patient? In that, all our actions, whatever we do, whether it be a procedure, whether it be starting antibiotics, are we going to create uncertainty or diagnostic issues later on? So we always need to consider when we're doing any procedure or when we're prescribing anything early on in the early phase, when there's some uncertainty, are we going to harm the patient in the sense that the patient is not going to leave with a possible diagnosis because of some of our actions? And then we briefly ran through the RLR illness script for COTI. Some of the risk factors are that duration of the Foleys, poor catheter care, and patients who are immunocompromised, and foremost amongst them being diabetics. And then, yeah, just again, some of the nuances now, because there was some diagnostic uncertainty in this case, would we consider sending the patient home on antibiotics? And Rabih shared a great pearl that if the patient is well, if the patient is happy, like I'm happy in the sense that if the patient chief complaint or problem was sorted out, then like send the patient home. Don't keep the patient unnecessarily. And then again, some of the nuances about whether to consider, in this case, the patient got well after the exchange catheterization. So there was a bit of diagnostic uncertainty whether it was that because of the mechanical obstruction, now that the patient is well with a replace and exchange catheter, and whether the patient actually had a UTI. In that case, consider what are we going to do by giving the patient antibiotics, and two things that we're probably trying to achieve is probably reduce severe infection in the future or prevent further obstruction of his catheter. Consulting ID in this case might be useful as what Maddie did. Yeah, thanks so much for a great case and enjoy the cruise, Maddie.
Thank you. Well, it wasn't a UTI. Well, we don't know who the UTI, but
that was phenomenal to capture all that back and forth and like a very confusing space. Phenomenal job, truly. I think that was special. I just have two requests. One is whoever's doing the whiteboard, if in parentheses by the DX, you can say Reza's DX early Cowdy. I want that on the whiteboard. And then my second request is that for our sign out today, I want the four of us to say UTI. I'll start it, then Rabih, then Zachariah, and then finish with Maddie, because we're trying to make a world record here in the number of times we say UTI. So again, I'll start it, then Rabih, then Zachariah, and then we finish with Maddie, okay? UTI.
UTI.
UTI.